Welcome back to the Pelvic Health Summit. I'm here with Dr. Jennifer Bonheur. She's a gastroenterologist. She practices general gastroenterology with an integrative approach, and she sees patients at her practice on the Upper East Side of Manhattan. Thank you so much for being here.
It's my pleasure. Thanks for having me.
So will you tell us a little bit more about your practice and approach?
Sure. As you said, I'm a gastroenterologist, so I specialize in conditions of the digestive tract, anything from the mouth all the way down to the other end of your GI tract. So acid reflux, stomach conditions, intestinal disorders of the small intestine, of the colon, the pancreas, the liver, anything that's involved in the digestion, in the digestive process.
Can you tell us how gastroenterology relates to pelvic health?
Sure. As a gastroenterologist, I certainly see a fair number of patients who will complain of pelvic pain or pelvic discomfort, and it's a very non-specific symptom. And so often patients will just complain of discomfort in their lower abdomen, in their pelvic area, and they'll come to me really largely to make sure that there's no gastrointestinal cause, or if there is, what that might be, so we can help treat their pain.
Can you tell us a little bit more about what some of those causes could be?
Sure. So within the realm of gastroenterology, certainly conditions of the intestine can cause pain in the lower abdomen or in the pelvis, inflammatory bowel disease, diverticulitis. Gynecologically, I always have to think about the other things that might be responsible for pain when a person comes into my office. So we think of conditions in women of the reproductive tract, so endometriosis, ovarian cysts, uterine fibroids, and we go through really methodically trying to work up patients who have had chronic pain to make sure that we understand all the things that either it is or it isn't.
Definitely. So can you tell us a little bit about the patient experience when they come to see you?
Sure. So that's one of my favorite parts of my job, is my interaction with my patients. I find that it's really important every time I see a patient, but especially a new patient, to understand who they are. And so I like to get to know my patients. So first they'll come in and I will just take a very detailed history. I will certainly be interested to know what brought them in, but I want to know all the other things about the patient. I want to know any other medical conditions that they may have had in the past or that they're currently being treated for. I will want to know if they've ever had any surgeries to make sure that any of the discomfort that they might be experiencing might not be related to scar tissue or adhesions from surgeries that they've had. But I also want to know who my patient is. So I want to know how they spend their days, who they are, where they come from, what their life is like, how they eat, what they eat. And I think that all of that is really, really important in my world for being able to come up with the right explanation for a person's symptoms and being able to treat them appropriately. It's one thing to make the diagnosis, and then it's another thing to know how to treat the patient. And how you treat the patient is really very often, to some extent, based on who the patient is. And so I enjoy that also just personally, because I like to know my patients and I like to know who they are, and I think it makes for a much more effective doctor-patient relationship along the way.
Definitely. Do you mind sharing with us a patient success story? And with telling us the story, we'll be able to learn a little bit more about your process and the treatment protocol.
Sure. I had a very interesting patient recently that I think is a perfect example of how there's an overlap between sometimes multiple different subspecialties in the context of pelvic pain. I had a young woman in her 30s, first time I had ever seen her, came in for pelvic pain. And interestingly enough, as I was, she just said she was having abdominal pain, lower abdominal pain, and rectal bleeding. And we started talking, and we really got into her history a little bit. And it certainly sounds like it should have been, strictly gastrointestinal. She's having rectal bleeding. There has to be blood coming from her intestinal tract. which there was, but the cause was really so interesting. And so we started talking a bit more, And I asked her, how often does it happen? And she says it happens a few days every month. And we talked a bit more, and it turns out that it was happening just around the time of her menstrual cycle. Every month. For month after month after month, she was having just this really uncomfortable pelvic pain, associated most of the time with rectal bleeding that would then completely resolve itself, and she'd be okay until the next bout would happen. And she came to my office. She had actually been, I believe, to a gynecologist, and maybe even had a pelvic sonogram, and everything was okay, or ended up in my office to help her understand. And we went ahead and did a colonoscopy because it was very curious to me that it was cyclical and that it was related to her menstrual cycle. And we did a colonoscopy, and it was a very, very interesting endoscopic finding. I saw in her colon a very unusual appearance. And I said to myself, and I said to her, I'm going to take a guess here, but I really, really think that you have endometriosis in your colon. And took a biopsy, and it was unremarkable because it was behind the wall of the colon. Sent her over to a surgeon, to a gynecologic surgeon, and after a couple more steps, she ended up having surgery. All subsequent biopsies were negative, still having this pain. She had surgery just about a week and a half ago, and it was endometriosis of her colon. So there was this incredible overlap between gynecologic and GI all together in pelvic pain, and we worked together between her gynecologist and a gynecologic surgeon and myself, and we made the diagnosis, and she's fantastic now. She feels so much better even a week or two after surgery. I think she's improved. So it was a really interesting diagnosis for me, and one of the very many examples of how pelvic pain can be a cause of can be a result of so many things, even unusual.
Yeah, thank you for sharing that with us. I know that when you get a diagnosis, that's part of the stress. So once you know what it is,
yeah, it's very exciting when you actually have a diagnosis.
And that's fascinating how the body works. So earlier on, you mentioned a little bit about food and the GI tract, and we've touched upon food and different things like that. But can you tell us a little bit about what makes up a healthy gastrointestinal system, and what can our viewers at home look at or kind of take note of within their own diets and their bodies to kind of assess how healthy it is, and if maybe they need to come see a gastroenterologist.
It's a mouthful. Most
Yes.
people don't like to say it because most people don't want to come to a gastroenterologist, really. Well, I think generally speaking, I am very much an advocate for healthy eating. So I think just across the board, I think that we are, as a society, probably not being as responsible as we should be in terms of eating healthfully, eating whole foods. We're probably eating too much processed foods, and maybe even eating not as much fruits and vegetables and fiber, and just overall healthfully as we could and we should be. But I think that the question of what should everybody be eating and how can you eat to ensure your own good health, that's probably an answer that is needs to be tailored for the individual patient. So, there are patients who have specific food sensitivities, either genetically or otherwise, and there are certain food categories that they can't eat. Patients who have celiac or patients who are lactose intolerant, and so they have to shift their diets to adjust for their sensitivities or intolerances. There are patients who have inflammatory bowel disease, and when they're actively inflamed, they have to rev down their fiber in their diet for a little while until the inflammation improves, and then they can go back to eating more fiber and more whole grains. And patients who have acid reflux or who have a history of ulcers, or sensitive stomachs, they may be more inclined to avoid acidic foods or foods that might relax the sphincter at the ends of the esophagus. And so there's lots of different ways that we approach diet, and that's part of the reason why I think it's so important to understand a patient and to understand exactly what they're feeling and to understand their lifestyle and what they can do, practically speaking. And so it's really a very individual decision and sort of strategy that we create for each patient. But I think overall, I've been a vegetarian for about 35 years now. It's been a really long time. I shouldn't say 35. I would say about 30 years ago. So I've been a vegetarian for about 30 years, and as I've gotten older, I've been even more and more aware of and even more of a proponent of it, just because I think it's a very healthy diet. But that's a very long conversation about food. I think that I love to have, but I think that overall, it's just really important to make sure that we are eating healthfully and in the right amount, in the right quantities, and paying attention to our bodies and recognizing the foods that make us feel better or don't make us feel well.
Definitely. I know just from my experience, it was a game changer when I realized, oh, eating that thing made me feel bad, even though in the moment
that's right
it made me
you don't
feel
realize
good.
it exactly.
So once I started realizing, so bringing that in definitely is very individual.
But one thing I can add, just in terms of diet and with respect to pelvic pain and pelvic health, one of the things that I think I end up finding often in people who come in with complaints of just lower abdominal or pelvic pain is constipation. And there's a perception that constipation just means you're not going to the bathroom, or that you're not going to the bathroom for several days in a row, and so you're constipated. And that's not always the case. Sometimes you can go to the bathroom and move your bowels fairly regularly, but have a sense of incomplete evacuation. And so you're not really completely having a movement that makes you feel comfortable, and that backup of stool over days and days and weeks can actually cause pain. And patients will come in with complaints of lower abdominal pain, and you take a closer history and you understand how they go to the bathroom, and you realize that there's probably some room for improvement. And if you simply just emphasize more fiber in the diet and balancing soluble and insoluble fibers and drinking enough water, sometimes it's that simple in terms of resolving some of the discomforts that patients are experiencing. Not always, but it's really nice when it is.
Yes, and touching a little bit on constipation, because I know it could be one cause of bloat. Can we get into bloating? Because not to be TMI, but I've been made fun of at dinner because sometimes I have to unzip.
You have to open the button or do the shirt over the pants.
Yes, and it's very uncomfortable. So
I've had patients get upset that they're tired of being offered a seat on the bus because they're just not pregnant, and it's that's definitely an uncomfortable situation to find yourself in. So bloating is an extremely common symptom. And it is an important symptom to pay attention to because it can be a symptom of something more concerning. So especially in women, and particularly as they maybe get a little bit older, but really at any age, if a woman complains of bloating or physical distension of their abdomen, and especially if they feel like their belly is distended and really kind of stays that way, and they're just getting used to it, and it's not always painful, but they just never had such a round belly before. Actually, the very first thing that crosses my mind, and that's really important for me to exclude as a gastroenterologist, is something gynecologic. So I always want to make sure that we're not missing something ovarian or uterine when I'm presented with a woman who is bloated. Once we've excluded that and we feel comfortable that there's nothing that's been missed in that regard, because that can certainly be a symptom of something concerning, then we can work our way backwards and figure out all the things that a person might be eating or doing or not doing, or how they're moving their bowels, or what kinds of things they may be doing that are contributing to their symptoms. Diet certainly can play a role, and again, it really very much depends on the patient. And there's a diet out there now called the Low Fodmap Diet. I don't know if you've heard of it. It's a diet that sort of helps to break down foods in terms of categories and helps to define the foods that tend to cause more gas and bloating versus the foods that cause less gas and bloating based on how they're digested when you eat them. And it's a difficult diet to follow for some people, but it's often an interesting guide to take a look at, because if you realize that you're eating all of these foods that tend to break down in such a way that they may be more responsible for gas and bloating, you can make some adjustments in your diet. There are certainly other conditions that can be responsible for bloating. There's a condition called bacterial overgrowth, small intestinal bacterial overgrowth. It kind of takes it higher outside of the colon, and it's an overgrowth of bacteria in the small bowel, and can certainly influence the digestive process and create symptoms of gas and bloating and sometimes altered bowel habits. But it'll create a general sense of abdominal discomfort for some people, and it's hard to really put your finger on it, because you can press on a person's abdomen and they can be sensitive all over, and they're coming in with symptoms of abdominal pain or distension or bloating, and you still have to methodically go through the differential of what makes sense for that individual patient, and make sure that you're not missing anything along the way before you just focus on diet alone. It's something that I will approach from the very beginning, but I just feel that it's my responsibility to make sure, if it's appropriate, that we're going through some degree of an evaluation to make sure we're not missing something along the way.
That's super important. Thank you for breaking down bloat. We had a gynecologist on a little bit earlier, and she was talking about the microbiome, and not only the gut microbiome, but also the vaginal pH and the different bacteria that can live in there, and was talking about how taking a probiotic could help. Can you tell us a little bit about probiotics and supplements and how those interact in your practice?
Yes, I think that's going to be the wave of the future. In medicine, it's going to be definitely one of the most fascinating elements of medicine that I think we're going to start better understanding over the next several years, I hope. I very much believe in the importance of the microbiome, certainly in the gut. I mean, it's almost hard to deny. All the studies that have come out so far have been fascinating, finding links between various strains of bacteria within the GI tract and influences that may have on susceptibility to developing certain medical conditions, susceptibility to obesity versus, or just to weight in general. They've done studies where they looked to see if they gave mice certain strains of bacteria and withdrew from others, and they saw that there were distinct differences in their weight just based on maybe exposure to certain bacteria, or at least it's been thought to be something worth looking into. Some interesting studies with respect to inflammatory bowel disease, and some unequivocal studies with respect to a condition called C. diff, which is an infection in the colon, and that's really the only indication that I am aware of right now for fecal transplants, which is where we actually take somebody else's stool, a healthy donor who's been vetted, I don't personally do fecal transplants, but I have sent patients for fecal transplants. It's done in a certain, you have to really have everything in place in order to be able to do something like that. But they will take healthy donors who fit certain criteria, not having certain backgrounds of any medical, conditions, and no other, active medical problems at the time that they donate the stool. And they will actually take that stool and place it into the recipient's colon, and the recipient being somebody who has a condition called C. difficile, which is an infection in the colon, and particularly in a patient who has been refractory to standard medical therapy. So they've not been, either they keep having repeated episodes, or they are just not responding appropriately to antibiotics. And it's astounding how well those patients do after typically prolonged courses of this condition, where they've been doing very, very poorly to get to the point where they need a fecal transplant. And you take the bacteria from somebody else and put it into somebody else's body who's clearly, struggling. And I think that's the true testament to the microbiome and how much of a positive influence, or how much of an influence in general, it can have on our overall sense of GI health. But I wish I had the answers. I wish I could tell you all the wonderful things that the microbiome is responsible for. I think that we don't really know, but I do know that it's going to be fascinating and incredibly useful, I think, in the practice of medicine once we have it better sorted out.
Definitely.
It's a work in progress.
I know that fermented foods and things like that have been recommended.
Yes.
Is there any time where, I guess a better question is, how can someone find the right probiotic for them, including foods and also supplements?
I don't think you really can definitively find the right one, because we don't really know what strains you should or shouldn't have based on what it is that you're treating. I think a lot of it comes down to trial and error for some patients. I tend to have a few probiotics that I recommend that I feel have been more often than not very effective for patients that I treat. I've gotten really good positive feedback from patients who have taken these probiotics, and they seem to be very helpful. But sometimes it's a matter of finding the shoe that fits. I'll have some patients that will do so beautifully on one particular probiotic, but not really respond to another. And when you make the change, it works for them, and vice versa for other probiotics. There really is no way to sort of map you out and see what you have and what you're missing and what your symptoms are. And if your symptoms are this, then you really need to have, in all certainty, this probiotic. There are some people who really don't even know that you need probiotics on a regular basis, but rather, like you said, eating fermented foods, eating a lot of fiber, diversity in your diet in terms of just lots of fruits and vegetables and a plant-based diet, I think has been shown to improve the diversity of your microbiome. So people who are more on like just a meat and potatoes based diet don't seem to have the same degree of diversity of their gut flora as people who eat more of a plant-based diet and have a more diverse diet. So I really do prefer that whenever I can, I come back to how people are eating and what people are eating, and making sure that we're optimizing that. But I'm not opposed to probiotics. I actually have found many patients do really beautifully on them. When they're on antibiotics, I'm a big fan. Just to help restore some of that gut flora that might be impacted by having been on antibiotics. But I don't recommend them categorically for everybody as a necessary supplement for good health.
Great, super informative. I loved what you said about diversity, and I think that that's a really good healthy goal for just mixing some new stuff in and finding what works. So going from eating to pooping.
We all do.
Sorry, we all do. These transitions, I'm just trying here. I don't know if this is a question you can answer, but I don't think we talk about poop enough. And
I do.
You do.
But that's
and I was wondering
job.
if you could tell us a little bit more about what's a healthy poop look like generally, and if we see XYZ, time to come in.
So patients will often come in and they have this notion of what their stool should look like and how often they should be going, and they should be going every day, and it should look like an S like they had seen on TV, and if they're not having a bowel movement in this way daily, something might be wrong. And one of the very first things that I will tell patients, just to sort of ease their anxiety over their poop, is that for me, there's a range of acceptable, bowel movements, and not only with respect to frequency, but also with respect to consistency of the stool. You don't absolutely have to go to the bathroom every single day. If you went to the bathroom 5 days out of the week and missed a couple of days here and there, that doesn't set off alarms or red flags for me. There's a certain point where I think you might, if you're not going to the bathroom more than once or twice a week, to me that's a bit too infrequent. So there's a range where maybe there's a degree of infrequency that might concern me, and then some people might go to the bathroom twice a day, and that's just normal for them, and that's okay. But if you start going to the bathroom 3, 4, 5 times a day on a regular basis, that's a bit more than average. And so on either end of the spectrum, I think there's a range of what's acceptable, and it comes down to really understanding the patient and sort of their general day-to-day experience. But beyond the individual patient, there still is a range where I think that my antennas go up and I start to wonder, like, maybe something else is going on here. So typically stools should be formed, and I tell that to patients regularly. It doesn't have to be exactly in the shape of an S, but it should be formed. That's the job of your colon. Your colon is essentially a really fancy dehydrating chamber, and after you go through the digestive process, largely takes place in the small intestine, the residual after the digestive process ends up in your colon, and your colon primarily is responsible for extracting the water out of the remains of your food and the digestive process that took place higher up, and forming your stool. And if your stool is not coming out formed, then something's wrong in the process along the way. Either there's some inflammation somewhere along the way that's preventing the colon, or maybe higher up in the small intestine, preventing the intestines from doing its job and being able to extract that water out of the stool, and so it can't work, and so the stool's coming out too soft or too loose. Or you're eating something that's interfering with this process, or your motility is too fast for other reasons and things are moving through you too quickly, either because of inflammatory conditions as well, or sometimes there are other conditions hormonally that can do this. I mean, the differential is enormous in terms of figuring out why a person might have diarrhea. And on the flip side, if a person's stool is too hard and they're having a hard time passing the stool, and they're only able to pass little bits at a time, but they're really straining and it's too hard for them to do that in any way that feels comfortable, then that can simply be a function of diet and not drinking enough water. There can be reasons why the colon is not moving as readily and appropriately as it should, and it's sluggish. There could be something getting in the way of the passage of stool, and that's always of concern to me, especially if there's been a change in bowel habits where a person was able to go and suddenly they're more constipated. So it comes really back to the very first thing that I think we talked about, which is one of the most important things I find when I treat a patient is to take a full history and understand everything about not just I'm constipated, but when did it start, and what is it like, and what's your normal been, and is this a change from your normal, or when did you start having diarrhea, did you travel anywhere, did you visit somebody in a hospital where they might not have even thought of that, but they could have picked something up in a place where they might not have even necessarily realized it. So I take really detailed histories, and sometimes can figure things out very simply just based on a conversation and nothing more. But in terms of what is normal, for the most part, a person should be moving their bowels every day to every other day, and typically it should be a formed stool. If you see stool that looks really dark or black or tarry, that's concerning in terms of whether or not there could be a source of bleeding really high up in the GI tract. It may not be as obvious because it's not red. Obviously, if there's red blood in the stool, that's always something that needs to be looked into. I never dismiss rectal bleeding. Stools that float are concerning, just in that you're potentially not absorbing fat appropriately, and so that means there might be too much fat in the stool, and that is causing the stool to float. I think that a clear understanding of a person's, bowel patterns and what their stool looks like is important, but then there's a range. There are patients who have conditions that might make that not so unusual. You have your gallbladder removed and it may actually change your stool consistency. You've had a history of chronic pancreatic problems, that may change your stool consistency, and then it's not necessarily normal, but it's explainable. So it's definitely a conversation that I have almost every day, trying to sort through what might be considered an abnormal stool on either ends of the spectrum. But it's an important conversation to have with patients. I think it is definitely an indication, a good indicator of certainly of digestive health and of their overall sense of well-being.
Can you tell us where we can find you?
Sure, I'd be happy to. My office is at 1317 3rd Avenue on the Upper East Side between 75th and 76th Streets. I have a website, www.bonheurmd.com.
Thank you. And can you just send us off with a message of hope?
Sure. I try to do that every time I see a patient all day long, just because I always have to remember as a physician that nobody likes to be on the other side of my desk. Nobody is usually there, happily being the patient. And so I think from a patient's perspective, it's really important to make sure that you have a comfortable relationship with your doctor, that you feel that you have an ability to express yourself freely and comfortably, and that you've put together a team of doctors that are really committed to your care. And there's always hope. I mean, you just have to find the right team of people, especially for patients that have chronic illnesses, the right team of people that are going to work together. I think that's very, very important, to have that synergy between healthcare practitioners, where everybody is really willing to communicate with each other for the benefit of the patient. And we always figure something out. We really do. And certainly I like to.
Thank you so much.
You're very welcome. Thanks for having me.
Thank you so much for joining us. Now I'd like to hear from you. Please share with us one takeaway from the interview in the comments below. Give us a like and share this group with someone who you think will benefit. Thank you.